Hello, everybody. Welcome to today's Research America Alliance discussion. I'm Jenny LeRae, Vice President for Strategy and Communications. As always, thanks for joining us today, and thank you for your organization's partnership with us. I've got to give a plug for membership. If your organization is not a member or you're not sure, we'd love for you to join us. Please reach out to my colleague, Anna Platt. She's putting her email in the chat, and she'd be more than happy to connect with you and discuss all the value that comes with being an Alliance member. So our very special guest today, and it couldn't be more timely, is Dr. Georges Benjamin, the Executive Director of the American Public Health Association and a Research America board member. Dr. Benjamin has long been one of our nation's top public health experts. So we've asked him to shed light on the ever-evolving COVID-19 pandemic. Where are we now and what the future may hold, not only with this pandemic, but with the likely future one. So as always, please type your questions in the Q&A box or chat, and we will pose as many as we can during the Q&A portion of today's session. So with that, Dr. Benjamin, over to you.
Thank you very much, Jenny. I'm pretty excited about being here. So let me just zip through these slides. You know, I like to always give my financial disclosure statement. Jenny hasn't written the check yet, so I don't have any finances to disclose. Just remind us, you know, this has been a big pandemic. We're almost at the million death mark in the United States. The good news is we've been talking about this million death mark for several months now. We've not reached it yet. That in some ways that's a good sign. And we know that the number of cases are undercounted, which we're going to talk a little bit about in a few minutes. But this has not been a good time for the last couple of years. This is a respiratory virus, and I want to just kind of reiterate that. I like to show this picture because it shows various particles of various particle sizes, some big ones and some small ones. That's important because we now know pretty convincingly that the three ways in which you get infected from a respiratory virus still hold. Most of the infection comes from droplet spread. Those are those large droplets that you saw in that picture. And aerosolization has been debated since the beginning of this pandemic. I can tell you that this is more infectious than influenza and less infectious than measles, but close. And probably some of the new variants are probably more caught through aerosolization than the big droplets, but big droplets still is the most common way you get it. Fomite transmission, where you contaminate an object, your hand, you touch a doorknob, someone comes behind you and touches that doorknob, then contaminates their face, their hands, and their eyes and get infected, is uncommon. But I think it's uncommon because we're washing our hands a lot. We're certainly not, as we go back to work, we may see more and more of this contact type of infection, but it's pretty uncommon. And so with routine cleaning, I don't think we have anything to worry about there, but just know that that is still a potential source of an outbreak, but again, very uncommon to happen. We know that this vaccination this vaccine prevents death. It is not as effective as preventing infections, particularly for people, even people fully vaccinated, but it's still pretty good. It dramatically reduces the number of days you carry virus and how much virus in your system. But its biggest benefit is preventing serious illness and death for people who are fully vaccinated. And that basically means the full primary series and at least one booster. We're at the point about 219 million people in our country who are fully vaccinated. It's about 66% fully. It's in the 80%, at least have had one shot. And about 40% of the people are boosted that are eligible for boosters. We know that from a global perspective, we still have some work to do. Here's the United States up here. And then all these other nations down here, some of the African nations like Nigeria are really under-vaccinated. We know that many of these nations have high seropositivity for COVID. So that means that people have been exposed to it. And maybe one reason why we're not seeing the bigger outbreaks that we anticipate coming up over the next few years. So let's talk about what's changed. Lots of Omicron variants and subvariants. We're all worried about BA1, BA2, these new subvariant of BA2.12.1, which is one that's now beginning to be recognized more and more, causing more and more infections. I think this is a phenomenon of not only the virus changing, but also we're getting a lot better at determining variants and subvariants. So our science is getting better here. We know that there are lots of tests now. We've gone from a shortage of tests at the beginning of the pandemic to a large number of tests. But these tests do result in underreporting because people are certainly not reporting their test results because they're doing them at home. And that could certainly impact our surveillance systems as we go forward. We have lots of vaccine around, but we still have a great deal of vaccine hesitancy. And of course, we don't have vaccine for kids 5 years of age and younger. We have pretty good antiviral agents now, a couple of them, but not a lot of the actual antiviral agent. I have a colleague who was trying to get the medication just the other day and had to wait. And quite frankly, that meant that they missed their 5-day window to take the antiviral. The good news is this person is on the mend, but the bad news is they could have been treated earlier with the antiviral agents had they been able to get a hold of them. We know that the monoclonal antibodies are not as effective, particularly for the new Omicron variant. And in fact, there may only be one that is positive at all. And that's questionable as we go forward. And then, of course, we know there's a big uptick in cases all around the country, but the overall mortality seems to be certainly flat to down. We know that the trajectory of this disease is going to be very important for us to think about for the future. So this whole issue of reporting test results and having a national strategy to do test results is going to be important. Right now, if your health department or your health provider gets your result and does your result, that's one way they get reported into the system. CDC does have some surveillance systems and is doing a bunch of community-based surveys, which is another way that we always get data and get some understanding where things are going up or things are going down. Hospitalizations, if we all of a sudden saw the surge in serious disease through hospitalizations, that's going to be one way. Those communities that are doing wastewater testing are showing that it's a really effective way to pick up this disease pretty early on. It turns out the disease, the virus itself gets secreted in your stool, and it's not infectious, but we can pick it up in wastewater. I think the challenge is that we still have some jurisdictions that refuse to share that result with the CDC. And that really shouldn't be. People ought to make sure that that data gets to the CDC. Routine outbreak investigations as we normally do them, trying to find new ways, as I said, to try to do more reporting of our self-tests. And of course, all these proximity apps. I've actually had this happen where I got a ding on my proximity app and said that, several days ago, I was exposed to somebody who now reports that they were positive. I, of course, was then able to go in and do my self-test, and I was asymptomatic, but I tested anyway. And of course, good news is I was negative. But those things do work, even though there's some delay in actually getting that information to the individuals. We do know that increasingly just gross case counts are becoming much more unreliable because of the underreporting of these results. So a structured surveillance system is essential for us to track the trajectory of the disease. What we want to know is whether it's going up or going down and when. And of course, what the variant is and what its efficacy is of our various prevention and therapeutic methods. We know that all viruses evolve over time. That's what they do. They're always going to go to the most vulnerable populations. They basically change their structure and how transmissible they are, how severe they are in terms of causing disease. And of course, the effectiveness of the therapeutics and prevention tools that we have. And you can see this is a picture of a SARS, the T spike on the SARS virus. And just know that it's a complicated protein. So there are lots of places for this structure to evolve. And of course, this particular virus, Omicron, which is the bulk of what we're seeing now, is probably not 72%, it's probably in the 80-90% range in the United States. And it seems to be a lot more infectious in asymptomatic people. We agree this degree of pathogenicity is still evolving. We believe that clearly it's showing it's not severe overall, but not for everyone. So if you're not vaccinated or fully vaccinated, and for people who have certain kinds of immune dysfunction, they're much more likely to get infected, and many of them are still getting severe disease. So there are lots of things that we still need to know more about this disease as it transitions. We're doing a much better job of ramping up our sequencing in the United States. We really didn't do a really good job before, but now CDC has rapidly begun ramping that effort up over time. So much so they've now shifted to a new strategy. I think everybody saw this strategy that came out, and they wanted to understand the basic population level immunity that we had, understanding what people were either vaccinated or tragically had been infected. The good news, they had survived, and that provided them some degree of protection. And because we have this breadth of tools, CDC felt they could change the criteria to a kind of a yellow, red, green stoplight chart as we went forward. And they're also looking at disease prevalence, hospitalizations, because that gives you a sense of the severity of the disease, and hospital capacity, because they still want to make sure that we can take care of people as part of the metrics they're using. On February 24th, when they rolled this out, this is pretty much what the nation looked like. The bulk of the counties in the country were either low or median prevalence, and that was a good thing. Now we're looking much, much better. Again, just remind you that there is some adjustment in this. We're now seeing some of the low prevalence counties now becoming median prevalent counties. So this map continues to change, and I just encourage people to check it out at least once a week to see what's happening in your community. But I think what's important here is it allows both a national series of recommendations to be developed, as well as local decision, using local decision making. So Philadelphia has been getting a lot of heat right now because they decided to remask. I just remind us all that they did this within the framework of the CDC, and then they made some specialized decisions based on data that they had in their city, and they have a high degree of people who have underlying disease processes. Therefore, they're more at risk, particularly because of the demographics of the Philadelphia community. And so they decided to be better safe than sorry, and they would require people to be masked. And I think that was absolutely the right decision for them. And that may not be the right decision in some other community, but it was truly the right decision for the Philadelphia community. But I think this framework allows us to, again, to use low, medium, and high, recognizing that everybody still needs to get vaccinated and boosted. But it gives you a sense of when you need to put on a mask, when you don't need to put on a mask, as an additional layer of protection from disease. I think the newest exciting thing is that yesterday CDC announced their new Center for Forecasting and Outbreak Analysis. My understanding this center is going to be in the Washington, D.C. area. They plan to bring on about 100 staff to do this. I think it will allow them to both do a better job of being like the National Weather Service, getting timely information, timely data, making it available to people, making it transparent, And then localities can then use that data for targeted data-driven decision-making. Clearly, this will aid both the public health community to inform policymakers a lot better. And if done right, it'll be a kind of a cross between the University of Washington modeling system and the Johns Hopkins Center, which is collecting a lot of data. And we'll be able to, as a system and a nation, to do much better data-driven decision-making. To make this work, they've got to continue to get their adequate funding. That means Congress and the administration have to continue to fund it and allow it to grow over time. They need to get the most up-to-date equipment to be able to do this. And they need to have strong partnerships outside of government, because there's a lot of very extraordinary expertise in centers of excellence all around the country that they'll be able to tap as part of this process. We know that public health legal authority is under threat. If you didn't know that before, this decision by a judge in Florida to precipitously end the mask mandate on public transportation just the other day is an example of, I think, just bad jurisprudence and sloppy jurisprudence. Having said that, it's created a lot of chaos in our transportation systems in our nation. We will work through it. My understanding, of course, is that in many ways, I think this is going to, we're going to be a mask wearing society by choice. People are going to decide now to wear masks a lot more. I was asked at the beginning of the pandemic by a reporter if we think at the end of this, are we going to be a mask wearing society? And my answer at that time was, I have no idea. But I believe that now that's true. I certainly carry my mask around with me everywhere as I go, and I wear it when I feel it's appropriate. I am fully vaccinated and boosted, but I want to make sure that I'm able to protect myself when I'm around a lot of people I don't know and don't know their vaccination status. We also know that the Justice Department may litigate that decision if, and the key word is if, the CDC decides the science says we need it. And this mask mandate was probably going to go away in another 10 days or so. So I don't know that it's worth the legal issue, except my concerns about the fact that this judge put in writing that the CDC does not have the authority to put in a mask mandate, which is absolutely not true. That is not the case. The Public Health Service Act clearly gives CDC the authority to do this. And it revolves around the word, the definition of the word sanitation. And the truth of the matter is that the mask cleans the air that you breathe. There's no question about that. That's just basic science. And I hope that we will now add a basic science course to all of our law students who now take it. So, the big debate now continues to be, what mask should I wear? And I just remind people that not wearing a mask puts you at 100% exposure to whatever's out there, regardless of your vaccine status. But if you have a cloth mask, and the way to think about this, and these are rounded numbers, okay? That cloth mask, about 60% protection in the real world. Surgical masks give you another 10%. And the high filtration masks, these N95 masks, about 80% in the real world. Understand that it does filter out 95% of the particles that you get. So it's highly effective. But like all masks, any mask not worn properly makes it less effective. So a properly worn, fit-tested N95 mask will filter out 95% of the particles. But most of us don't do that. Most of us go and buy a mask, we put it on, we make sure it's tight, and we still breathe around that mask. So it's not completely effective. But your goal is to be fully vaccinated and then add these masks as another layer of protection. And just to remind you, it's a two-way street. I wear the mask to protect me, and you wear the mask to protect you. And together gives you even greater protection. Just to remind you that the industry is looking at boosters and second generation vaccines. Moderna just is put out a press release. No one's seen the data publicly yet, but about some multivalent vaccines. So I just think there's some neat work going on to try to get a vaccine to kind of be more effective and to try to anticipate what the next variant will be. We do have some concerns going forward. We still have significant issues with our supply lines for materials. That's one of the reasons we don't have enough antiviral agents. We still have PPE shortages, although this mask mandate may free up a lot of masks. So there should be a plentiful supply of masks out there, but we still have some issues around our supply line. We certainly have some issues with health workforce staffing, both medical care as well as nursing, as well as public health. Our testing capacity right now is fine, but going forward, particularly if we get a new variant that begins to escape the vaccine, I have some concerns about testing capacity. As you saw, the whole issue about our regulatory advice, and are people going to follow it, and are the courts going to undermine it? Vaccine mandates, continue to be controversial in many settings. Getting access to global vaccines. We still need to get the money to make sure we can help vaccinate the world. We really don't know what the future vaccine schedule is. Is it going to be every 6-month vaccine? Are we going to do it annually? Are we going to even need to be vaccinated again at all? That still remains to be seen as we go forward. And we always talked about the more new variants. I think one of the biggest issues on the table right now is the chronic COVID syndrome, really trying to get a good case definition of what it means, what its clinical course is, what its natural history is. All those things need to be developed. NIH has some research protocols right now looking at chronic diseases from COVID, but there are going to be all kinds of people who are going to need to be studied on chronic COVID. And then we just had some reports in the last few weeks about animal to human transmission, particularly around minks. We've always known that other animals can get COVID. They can certainly get coronaviruses. There are animal coronaviruses that are different from human coronaviruses. And we're going to have to understand what the role now is of transmission from animals to humans, and maybe humans to animals, and what that means in terms of the transition of transmission of this virus. And then finally, this whole issue of violence against health workers, which is something we just need to figure out how we stop this. We still got people that are getting angry at the health workers in hospitals for a variety of really bizarre reasons. And we still have health officials who are still getting nasty emails and threats against their health. So with that, let me stop and take questions.
Thank you, Georges. What a fabulous presentation. I mean, it was so comprehensive, and you touched on so many of the key issues. We'll certainly make your slides available on our website. So I'm going to use my host prerogative and kick off with a few questions. I want to ask you about vaccination and access versus hesitancy in the US. I mean, clearly, as you noted, access is still a big issue outside of the US, but in the US, to what extent are there people who would like to be vaccinated and don't have access? How much of an issue is that still? Or is it mainly those who are hesitant or unwilling? And I guess the hesitant could be put into that access group as well. So what are your thoughts?
Well, we still have people who are violently against getting a vaccine, and for a variety of reasons. And then we have people who are still who are still fundamentally hesitant or confused about the messages that they've heard. And then we have a bunch of people who just haven't gotten around to it. They're not necessarily that opposed to it, but they haven't become concerned enough to get vaccinated. They're going to work. It's not convenient. They haven't gotten sick, at least they don't think they have. And they just, haven't seen the devastation yet enough, frankly, to scare them enough to go get vaccinated as a priority in their day. So but understand that we've always had that. That's not new. We've had that anytime we brought out a new vaccine. It's taken us years. In fact, it's been remarkable that we got as many people vaccinated so far as we have.
Thank you. So we have a new White House coronavirus czar, formerly called the White House COVID response coordinator, Dr. Ashish Jha, who you know quite well. And we actually recognized him last month with our Meeting the Moment for Public Health Award. What do you think should be Dr. Jha's focus right now, knowing that you have probably shared some of your thoughts with him already?
Yeah, I think the first thing is obviously one of the biggest issues he has to do is get his hands around government and help make sure that we have a coordinated message. Because a lot of the loss of trust, a lot of the confusion out there is the lack of a coordinated message. The other thing is trying to get ahead of events, because we continue to chase events. And that means that if a judge decides to do something that doesn't make a lot of medical sense from our perspective, and we probably ought to have a game plan in the can for that. And sitting around doing some, gaming and thinking about what I mean by gaming, intellectual gaming about messaging and what do we do if someone says this or this happens, et cetera. What do we do if the virus does X, Y, or Z? And getting people to think about what the messaging is on that and what we should be telling people what to do around, what do you do around testing? What do you do around isolation and quarantine? What do you do about opening and closing events? What do you do about wearing a mask? So to the extent that we can tell people what to do and have that stuff thought through by a group of people, kind of sitting on the side, the B team, Julie Gerberding used to call them, and then having everybody prepared when that happens, or to preempt it before it happens, so that you can rapidly, in essence, control the message, I think will help bring some rationality and trust to the process. Thanks. So that's one thing he needs to do. And then, look, the science is going to work. I mean, the fact that he's a physician, the fact that he's done public health for so long, the fact he's been involved in global health, he knows how to make the trains run. He knows what we need to do. He didn't have a startup curve on that. His startup curve is, knowing who to talk to first about moving the president's agenda to protect the American people in a holistic way. So I think in many ways, he's going to be a strong advisor to both the president, but I do hope that the Secretary of HHS also sees him as a strong advisor to him.
I'm going to ask one more, and then we'll turn to our audience. You served as the health secretary for the state of Maryland, which is when I think I first met you. How has the pandemic changed the role of state and local governments in protecting public health? Are they playing a bigger role? Are we seeing new models of partnership with the CDC and local officials?
I think that we are playing a much bigger role across sectors than we've ever done before. We got to do what we did in our wheelhouse all by ourselves. Usually nobody knew what we were doing. We opened and we closed things. We interacted with the private sector, and really, I think we were pretty transparent about it, but it just didn't rise to the occasion that the media made a big deal about it. It was 4:30 on a Friday afternoon, and you had an 800-person foodborne outbreak. You certainly had to notify the governor's office, but it wasn't generally something that they were looking over your shoulder about. But nowadays, if you do anything, we're now in a fishbowl, and so I think managing in public health is very different. The operating environment is much more visible. It's everything we do is much more political, or at least it has the potential to have a political element to it. And so I think it requires new thinking on us. And, the people who have time to get on social media and cause havoc with misinformation and sometimes purposeful disinformation, we're busy managing in taking care of people and trying to protect the public. And unfortunately, we really don't have the time to battle with them in the social media space. So you're always chasing bad rumors. I think that's the one thing that's very different. I also remember, as you know, when I was the health secretary in Maryland, we had the anthrax letters and we had 9/11, and the nation was united. We didn't have all these political side discussions going on where our activities were being undermined by people for political purposes. That's changed.
It's a good observation. I'm going to recognize my colleague Anna Platt to the screen to help us with lots of audience questions.
Yes, absolutely. Thanks, Jenny. And as a reminder to folks, please feel free to put your questions in the Q&A or the chat, and we will do our best to ask them. So Dr. Benjamin, one question that's come in: how would you assess the extent to which the general public or segments of the public has lost trust in public health authorities and public health experts, and what can be done going forward to rebuild that trust and look at lessons learned there?
Yeah, trust is hard to develop and easy to lose. And the best way you do trust is by what you do. Less talk, more action. And so I think if people continue to see us trying to do what's right and protect them, then we will win them over. There's always going to be a bell-shaped curve, skewed left or right, with people who are going to be on outliers on both sides of any political debate. But having said that, I was always taught that when you have a tough decision to make, if you do what's in the best interest of the patient, and expanding that, because that was when I was an ER doc, expanding that to the discussion of the public, doing what's in the best interest of the public, then even if somebody gets mad at you, I get to sleep well at night. So I want to sleep well at night. And so I'm always going to do what I think is in the best interest of the public. And I'll let the flack come in. I'm tough. I can handle the flack. And I think anyone else in public health ought to do what's right, and let the politicians do what they do, and people who want to be the naysayers do what they do. But at the end of the day, I've got to live with my own conscience, and I've got to do what I think is scientifically, ethically, morally correct, and speak up for it.
Thank you very much for that. Another question, in your slide deck, when you had the different types of masks there, and under the N95, this person is saying, can you perhaps explain a little bit more what you mean by a mask can be reused 5 times with proper care? If you just put the mask on to go into the grocery store, does that count as one time? But what if you wear the mask for a longer period of time? So can you go into that a bit further?
Yeah, people shouldn't overthink that. The idea is that you wear the mask for whatever period you're doing it, you take it off, you clean it, you put it away in a bag so it doesn't get soiled. It's not, you don't just dump it on your bedside night table and put it back on the next day, because it's going to get soiled, it's going to get contaminated. The problem is that, remember, this is a piece of material that has pores and overlapping materials. And so grease, if it gets wet, all those things impact the ability of it to be an effective barrier. So people that have kind of done studies have said, yeah, if you take care of it, you take it off, you put it in a bag, you can probably wear it for 4 or 5 days. Now, having said that, I'm sure I'll get all kinds of emails from people saying, oh, that's not what they said. And the truth of the matter is, I encourage people to have several masks and, wear it for a day and then throw it in the wash and get the new one, out your drawer and wear a fresh mask every day. And I wear a mask around a lanyard around my neck. And so as I'm walking around, I put it up when I need to put it up, and I take it down when I need to take it down. And I wash my hands frequently, either, soap and water or the hand sanitizer, and put it back on. If my mask gets soiled or wet, then I replace it, even if it's the same day. And I think that's probably the most effective and practical way to do that. And I think one of the challenges we have is that people want exact science. They want to know that if I put this thing on, it will 100% protect me from X. And the truth is, life doesn't work that way. The only way, if you want to be 100% protected from COVID, is that you're going to have to live in a bubble somewhere with negative flow and not come out for anybody. And we're not going to live that way.
Right. That's no way to live. So another question that has come in, what would a new vaccine candidate look like that differs from the current way the vaccine is made?
So they'll make the vaccine the same way, but there are several things that they might do. So they could put several different variants in the same formulation. So they could put the alpha variant, the beta variant, the delta variant, a couple subvariants in there. When we make flu vaccine, it has different strains of the virus in it. So they can do that. They could decide to make it targeted to a very specific strain. But of course, these change a lot and it will be less effective over time. They could find another part of the virus that is universally antigenic, meaning it creates an immune response, but does not change very frequently. So imagine another part of the virus structure that doesn't change or mutate very often, but in it itself continues to create an effective immune response, meaning the body recognizes it as foreign and creates a very specific response to attack that part of the virus or inhibit the virus from working. So they can find another portion of the virus to go after. And then, they could use another, right now, we have the mRNA vaccines, and then we have those that are adapted on back of the other viruses. So they could use another, and they call those platforms. They could decide to use another platform that over time gets discovered to be more effective than the mRNA platform they're using right now.
Great, thank you. So this person is saying thank you for this important update, and we all share that sentiment for sure. And can you please comment on present and future vaccine requirements in the workplace? Any thoughts on that?
Yeah, I think we're all going to accept being fully vaccinated for sure, and probably boost it as kind of the baseline office requirement. I don't know that we're going to get to the fourth vaccine booster as a requirement anytime soon. That may turn out to be a requirement in specialized places, cancer centers, places where people are dealing with people who are really at risk. They may have a higher level of requirement. But I think we've got to get a better sense of how durable the vaccines are we have. Just remind you that what we know is about 2.5 years old at the most, about how durable these vaccines are, meaning how long they stay effective, how rapidly they degrade over time. And we're focusing like a laser a lot on the neutralizing antibody, which is the first part of the immune system. And we really haven't done a lot of work yet, even though the research is looking at it, on what we call cellular immunity. And that's the part that gives you the much longer protection in your body. And it could turn out that even though people, once we get over this kind of phase of these rapid variants and enough people are immunized, either through the vaccine and tragically because of infections, but the population protection level is high enough that we could get to a point where we just have seasonal or episodic outbreaks of this disease without a lot of real serious morbidity or mortality. And in that situation, it's our cellular immunity, that long-term immunity, keeping people from getting really sick and dying. I don't think we're there yet, but I do think that is one possible future as we begin to understand it. And then there may be some ways for us to figure out how we even emphasize that more with the vaccine. In other words, do a better job of not only improving the neutralizing antibodies that are initially developed, but also enhancing the cell-mediated immunity that occurs later. You've now exhausted my entire immunology knowledge from medical school.
Well, we're gonna now go to public-private partnerships, so you can take a break from immunology, Dr. Benjamin. But we have a question, which is, can you provide any examples of sustainable partnerships that started during the pandemic? And I know that APHA really helped to launch the Alliance for Disease Prevention and Response, which I think in part was your effort to create public-private partnerships. So could you share any successful partnerships that have come out of that?
Oh, no question about it. So the Alliance is a group of cross sectors, and our goal was to try to engage the community to strengthen the response in a variety of ways, to set a table where people could share information and not kind of reinvent the wheel. We were seeing a lot of that reinventing of the wheel going on. It always happens when we do these kinds of things. Our strategic partner on this is a group called Shared Cause, Steve Greeley and his group. So let me give a shout out to Steve Greeley and his group as a strategic partner for that. We also partnered with the group Made to Save, which was a vaccine coalition that was put together that has done amazing work. And we certainly participated with that. The Blacks Against COVID that Reed Tuckson and others put together, which was very focused on the African-American community. We had a partnership with the National Academy of Medicine, which continues a very strong webinar series, again, trying to bring up science-based evidence, because while there was certainly a lot of science going on, we felt disseminating that in an effective way was very important. So we did a series of webinars around science-based activity around COVID. And I think the Alliance, as for example, is going to continue. And now what we're doing is pivoting to building the public health system of the future. And as you may know, there's a lot of work groups that have focused on papers on what we need to do. And what we're trying to do now is bring all those groups together to agree on a pathway and to agree on prioritization. And I think the fact that CDC now has this new center is going to be very important for modeling. The fact that we have this commission that the Pew folks, not Pew, Commonwealth Fund put together, that Peggy Hamburger is going to look at the how best to focus and improve the federal response, I think is going to be very important, particularly around CDC. So we got these little groups. The Bipartisan Policy Center did a very wonderful piece of work around what we need to do. And I think what we need to do is we need to continue to remind Congress to finish the job. I think the one thing we need to do today that's most important is push Congress to I think we need the $22.5 billion, even though I know they negotiated down to $10 billion. It was $15 billion with the global piece. But we need to do this. Congress needs to come up with this. I believe they need to stop saying that we're broke, because they find money to spend money on anything they want to spend money on. And from a public health perspective, $15 billion is a rounding error in the federal budget. Now, no one should leave this thinking, I don't think $15 billion is a lot of money. I would love to have 1/10 of that money to do good public health stuff. But considering we had a multi-trillion-dollar impact on our society alone, $15 billion is chump change to begin to try to finish the job. So I think we ought to continue to push that.
George's, if I could just ask you to just put some fine lines around, where do you think the supplemental money is most needed right now?
Well, first of all, we need to reestablish the ability for low-income individuals to get their care taken care of. The fact is we're going to have, huge health inequities around the fact these people aren't able to get care. Access to therapeutics is the next one. People are already having trouble getting it because of the supply line problem. And if you're low income, you're going to be essentially shut out. I think global money for the global vaccine program is probably the third thing on my list. And then I think long term, we need to figure out how we keep these folks that we brought into the Medicaid program in the Medicaid program. Those folks that are going to shift to the health exchanges, we need to make sure that the premium supports stay for those. Look, we could easily, once this emergency go away, 15 million people have a risk of losing their health insurance. I won't say overnight, but very, very quickly. And some of them will be eligible for the exchanges, but at a very steep cost for their premium coverage, which ultimately will mean they'll be uninsured. And so we need to make sure that we very carefully unravel these emergency procedures that we put in place. And I think that's important. Let me say one other thing. We need to put some money in for public health systems research. There's a lot of things that a good public health research agenda would have helped us understand, such as how do you get shots in the arm? That last mile stuff that we have a lot of science about what to do. We didn't do it, but not enough. How to better structure our health departments in the nation. We still have a dysfunctional organizational structure for public health. And we need to have the research to prove that. We need to study the benefit of accreditation. I believe that every governmental health department needs to be fully accredited. And we need to have the resources for them to become accredited. And we need to be able to better define the benefits of accreditation, just as we do for hospitals and other health systems. So those are some of the things on the top of my list. And then we got a whole research agenda that still needs to come out.
Thank you.
Thank you, Dr. Benjamin. Yes, thanks, Jenny. Dr. Benjamin, another question that has come in. Can you talk a bit about how public communications by public health authorities and experts are tested, honed, assessed, improved, or changed over time? This person is wondering, are the focus groups used or analytics? Can you talk about that a bit?
No, somebody puts a camera in front of your face and you say what's on your mind. Public health is so broke. We don't have money to do focus groups or testing. I mean, we've been fortunate that there have been a few groups like the DeBeaumont Foundation who have generously provide some money for us to do some testing. They got Frank Lutz, who's a Republican pollster, to go around and help us to do some focus groups, et cetera, and try to talk better and more informed to conservative communities. You had the folks at Harvard who periodically have done some surveys in their health policy shop around public health, but we do not have a funded, robust, scientifically based communications program for public health in the country. I think if you think about it, the good news is all those folks that got MPHs over the last 40 years, many of them were able to find a TV camera, and some of them turned out to be incredible communicators. Some of them not so much. But there was a mismatch there. A lot of people talking were kind of the armchair epidemiologists like myself, right? We did not have enough of the people in the field, actually working health officials in front of the television cameras, in front of the radios. They were in their communities, but not nationally. And I think that's something we need to change. We've added communications as a component of the various leadership programs that we've had over the years. I mean, I had my first professional training in communication from the American College of Emergency Physicians when they wanted to make me a member advocate for the organization. And we went through communications training back then. So that takes me back to many, many years ago when I was much, much younger. And I've tried to get as much experience communicating. And I can tell you, I'm certainly not one of the best communicators in the country. There are many people out there that are extraordinary. But I have had the opportunity to have enough training so that I usually don't screw it up and usually don't trip over my words. But, sometimes I do. And I think we have to have a system in place to do a better job helping people communicate. I think the biggest failure, and there was a failure, is the fact that we didn't command the conversation. So, when you're about to make a major policy change, that's a press conference. That's sitting in the room with the media at your beck and call, and you sit there and you explain in intimate detail what you're planning to do and why, with all your scientists around you and all your verifiers all keyed up to verify what you're saying makes sense. And you need a game plan to push back on the naysayers in an effective forum. And you have to never be afraid to go talk to anybody, whether it is the most conservative media or the most progressive media, the most hostile media. You have to be prepared to get in front of those folks and defend your position, and do that with a degree of integrity so that people trust you. Ashish Jha was very successful at doing that. And in many ways, this is why he has the job he has today. Julie Gerberding, when she was CDC director, extraordinarily effective communicator. C. Everett Koop, when he was Surgeon General. David Satcher as Surgeon General. These folks were extraordinary communicators. And in case many of those folks were involved in communicating in crisis. So I think crisis communication and risk communication is a tool that we need to make sure everybody in public health has. And they need to just become more experienced at it.
That's so interesting, Dr. Benjamin. Thank you. One additional question. I know we're coming up to time, but before I turn it back to Jenny, Dr. Benjamin, this person has said, as we know, that having timely and reliable, high quality data is critical to doing the best surveillance for disease. And how do you propose we have a national system that will easily and readily provide that type of data from across all sectors? We've talked about the new initiative from CDC. What do you see as the first and future steps in that space?
Yeah, the forecasting center is part of it, but it's a very specialized entity. We need to have the same data system with speed and accuracy and flexibility that Amazon has, or pick another online retailer. Right now, if you want to manage a health event in a community, we're still using fax machines. For the young people in the audience, fax machines are things that actually you take a piece of paper, you put it in the machine, and it actually takes a photocopy of it and it sends it over the wires. And I know none of you have ever seen one of those before because they're antiques. They kind of go with rotary telephones, if you know what a rotary telephone is. But seriously, public health departments are still writing stuff down on pen and ink, putting them in fax machines and faxing them to folks. And then if a box is not checked, you're 4 generations from where that data was collected before you realize race and ethnicity or gender or even the lab result wasn't put on the piece of paper. And then you have to spend hours reproducing that information. You have to spend hours deduping information, knowing that George Benjamin in data set 1 is the same George Benjamin in data set 2. So we need to fund and build a national data highway system for public health that's interoperable with all state and local health departments, including our healthcare community. And we need a single patient identifier so that we don't have to continue to dedupe it. And I can tell you that if I buy something from Amazon in my office, and then I go buy it from my home, Amazon doesn't confuse who I am and where to send that package. And we need, but if you want to do that at EKG and go to one doctor's office and then go to another doctor's office, if they're not in the same plan, same network, that data never gets put together. That's why we continue to have to do multiple x-rays, multiple lab tests, all those kinds of things. It makes no sense. And that's what we need to do first, because we're a data-driven discipline.
Absolutely. Thank you, Dr. Benjamin. And Jenny, I'll turn it back to you.
Well, Georges, we can't thank you enough for spending time with us today. First of all, you brought us up to date on a lot of important issues, COVID variants, masking, et cetera. And you've made some really important recommendations, both around the need for better infrastructure and other uses of technology, and also skills like communication. So this has really been terrific. Thank you. Thank you so much. And this talk will be on YouTube. So please share it with your friends. Those of us who are in the audience, we will spread it far and wide. Just quickly, on tomorrow, actually. Please join us for our annual meeting. It's at 1 p.m. Eastern, and a link to register is in the chat now. It's going to be a very good meeting with some important conversation and updates. Thank you. Have a great day, and we look forward to seeing you again soon.